Okay, in our video series of pulmonology lectures, in this video, we are going to talk about chronic obstructive pulmonary disease, COPD. We are going to discuss the presentation, the diagnosis, and treatment of COPD according to the latest GOLD guidelines in detail. First of all, COPD is a chronic obstructive pulmonary disease characterized by airflow obstruction, which is caused by a mixture of small airway obstruction as well as parenchymal destruction in the lungs. Now remember that it is an obstructive disease. In obstructive diseases, patient has difficulty in exhaling the air out of the lungs, in taking the air out of the lungs. Because there is parenchymal destruction in the lungs, the small airways are obstructed and a patient cannot exhale the air out. That is called as chronic obstructive pulmonary disease. Now remember, in our asthma video, we said that asthma is a reversible obstruction that can be reversed. But COPD, on the other hand, is irreversible. COPD is an irreversible obstruction because there is parenchymal destruction of the lungs leading to airway obstruction. This is a picture showing the parenchymal destruction of the small airways. Now, COPD is divided into two main groups, chronic bronchitis and emphysema. Chronic bronchitis is a productive cough for at least 3 months each year for 2 consecutive years. For the 2 consecutive years, each year patient has at least 3-month period in which the patient is having excessive productive cough. The patient is having productive cough because it occurs mainly due to smoking. There is damage of the bronchi and bronchioles. In the bronchi and bronchioles, there is excessive mucus secretion from the glands. That excessive mucus secretions in the bronchi and bronchioles causes blockage of those bronchi and bronchioles. Blockage of bronchi bronchioles causes obstruction of the airflow out of the lungs. That is called as a chronic obstructive pulmonary disease, and that is the presentation of chronic bronchitis. In emphysema, what happens is that there is permanent dilation of the pulmonary air spaces distal to the terminal bronchioles. In emphysema, there is problem with the alveoli. There is destruction of the alveoli, the small air spaces where the gas exchange takes place. In chronic bronchitis, there is problem with the bronchi and bronchioles where it is hypersecreting mucus and causing obstruction. In emphysema, there is destruction of the alveoli, and destruction of the alveoli causes obstruction of the bronchi and bronchioles. Now remember, in real life, there is a lot of overlap between these two diseases. In real life, the patients would be exhibiting symptoms of emphysema, destruction of alveoli, as well as chronic bronchitis, excessive mucus production. So the COPD patients mostly have both of these. Now coming to the causes of COPD. Causes of COPD include exogenous causes and endogenous causes. Exogenous causes include tobacco exposure. Tobacco is the most important cause of COPD. 90% of the cases are due to smoking. Almost 20 years of smoking causes excessive damage to the lungs, resulting in COPD. Exposure to fine dust, silica, coal miners causes obstruction of the lungs. Wood, animal dung are burning indoors. These chronic exposures throughout the years cause damage of lungs and resulting in COPD. But tobacco is the most common cause. Now coming to the endogenous causes. In endogenous causes, alpha-1 antitrypsin deficiency is very important because many times young patients come to you in your clinic and they are having COPD. They are not smokers, they have not touched cigarette throughout their life, and they are young and they have developed COPD. This alpha-1 antitrypsin deficiency must be a differential because alpha-1 antitrypsin is an enzyme that prevents destruction of the lungs by elastases. Now, if alpha-1 antitrypsin is deficient, elastases are free to destroy the lungs. Therefore, if alpha-1 antitrypsin is deficient, elastase will destroy the lungs. IgA deficiency and Cartagena syndrome are other causes of COPD. But the two most important causes are tobacco in old people and alpha-1 trypsin deficiency in young. Now coming to the classification of COPD. COPD is classified based on the GOLD classification, Global Initiative for Chronic Obstructive Lung Diseases GOLD classification. GOLD classification is done based on the spirometry. In spirometry, what they do is that spirometry is a machine in which a person is asked to exhale forcefully. When the person exhales forcefully, it is recorded that how much air has that person exhaled out. So if a person has obstructive disease, then obstructive disease person cannot cannot exhale out the air properly, so the values are low. That values are recorded as forced expiratory volume in the first second, the amount of air that that person exhales out forcefully in the first second. So gold class 1 includes the patient that have mild symptoms and their FEV1 forced expiratory volume is normal. FEV1 greater than 80% of the predicted is a normal value. If a person has less than 80% of the FEV1, that is abnormal. Now, in the subsequent ones, deduct 30 from each one of these. In gold class 2, patient has moderate symptoms, and if you deduct 30 from 80, it's 50. So the patient is having FEV1 of 50%. And in class 3, the patient is having severe symptoms, and it is around 30 to 50% of the FEV1. And in gold class 4, the patient is having severe obstruction, and less than 30% of forced expiratory volume in the first second is noted. So the patient cannot exhale the air out. Now, slightly going into the details of gold classification. Gold classification uses some scoring criteria like CAT score. In CAT score, what they do is that they give some questionnaires to COPD patients, and in questionnaires they ask that how many times they have the phlegm production, how many times are they coughing throughout the day, how many times do they feel breathless, how many times do they feel chest tightness, symptoms like this, and those patients fill up those forms, and according to that they score it. Other than that, MRC dyspnea scale is also used. In MRC dyspnea scale, they classify the patient according to the symptoms of dyspnea that that patient develops according to the activity. After how much activity does that patient develop symptoms of dyspnea? If the patient is developing symptoms of dyspnea on exercise, that is given the score 0. And if the patient is developing symptoms of dyspnea after even changing the clothes, after moving out of the house, the patient develops dyspnea, that is given the score 4, that maximum score. Now I am telling you these two just to give you an idea, basic idea about how gold classification is scored. Now, according to these scoring criteria as well as the symptoms and exacerbations per year, they classify the patient into 4 groups: COPD A, B, C, and D. And we will discuss the treatment of each one of these as well. In COPD-A patients, the patient gets exacerbation of less than or equal to 1 times with no hospital admission in a year. So that is COPD-A and B. The symptoms are mild symptoms in A and severe symptoms in B category. And this is the dyspnea scale. In COPD-A, it's less than 2, and in COPD-B, it is greater than or equal to 2. In CAT score, it is less than 10 or greater than equal to 10. You do not need to remember the details about these scoring criteria, but I'm just telling you just these to give an idea about how it is classified. In COPD-C and COPD, the exacerbations are greater than or equal to 2, and in COPD-D group, it is greater than or equal to 1, but it is so severe that it leads to hospital admission. Mild symptoms, severe symptoms, and the dyspnea scale and the CAT scores. So this is how they classify the patient into COPD A, B, C, D category, being COPD A being the most mild one and COPD D being the most severe one. Now, coming to the presentation of a patient with COPD, a COPD patient will have a history, long history of tobacco smoking, and now the patient has developed chronic cough with mouth full of sputum. There will be dyspnea, tachypnea, even on slight exertion. The patient will be dyspneic, short of breath, and initially it will be only present on exertion, and later on in the later stages, the patient will have continuous dyspnea. And remember, these patients will be having pursed lip breathing. What is pursed lip breathing? This is pursed lip breathing. These patients will be breathing like this. They will be applying force while exhalation. They'll be exhaling out some air, but they will be forcefully keeping some air in as well to keep the alveoli distended, to keep the alveoli open, since these alveoli are destroyed and they tend to collapse, and they purse their lip forcefully to retain some air so that these alveoli do not collapse. There will be prolonged expiration. Patient will be present in a tripod position. Tripod position means that they will be keeping their hands on their thigh, leaning forward. This helps them to exhale the air out. They cannot lie down straight, so they will be having many pillows on the back. Their hands will be on the front, they will be leaning forward, and their lips will be pursed, forcefully taking the air out. Now, coming to the diagnosis of COPD. In the diagnosis of COPD, spirometry is the most important test. In spirometry, what they do is that they ask the patient to inhale fully to inhale to their full, and then they ask the patient to put this device into their mouth and exhale air out forcefully through the mouth, and then this device detects that how much air that person has exhaled. That is called as forced expiratory volume 1 in the first second divided by forced vital capacity. So these patients are unable to exhale the air out forcefully, therefore the FEV1 will be low, and FEV1 to forced vital capacity will be less than 70%. Now FEV1 will also be decreased, and FEV1 to FVC ratio will also be less than 70%. Now, as I said, that chronic bronchitis, the alveoli are totally okay. Alveoli are fine. The problem is with the bronchi and bronchioles, which are obstructed, which are plugged with mucus and they are blocked. In emphysema, the alveoli are destroyed. So a test to differentiate that whether it is chronic bronchitis or emphysema, since both are obstructive disease and both will show FEV1 to FVC ratio less than 70%, both are obstructive diseases. So to differentiate between these two, what you can do is that you can perform DLCO test. Now, this DLCO test is not performed in common routine. Spirometry is usually enough for the diagnosis because these patients of emphysema and chronic bronchitis, both diseases have a huge overlap. Patients usually have both of these. But for academic purposes, remember that in chronic bronchitis, the alveoli are fine, and we give small non-lethal amount of carbon monoxide. The person inhales it, and we see that how much it is absorbed in the blood. So in chronic bronchitis, the alveoli are fine, and carbon monoxide is absorbed properly. But in emphysema, the alveoli are destroyed and carbon monoxide cannot be absorbed. So that's how you differentiate with diffusion of lung with carbon monoxide. Now remember, if spirometry is normal, COPD is excluded. Remember that COPD is an irreversible disease. COPD is always there. Patient has a baseline disease, and sometimes patient gets exacerbations. How to manage those exacerbations? I have talked about it in detail in my video on COPD exacerbation management. You can check out the link in the description below. So patient always has a baseline disease and patient gets us exacerbation. Unlike in asthma, where patient is totally fine, totally healthy, and patient gets asthmatic attack. So the patient always has a problem, patient always has a disease. Spirometry, if it is normal, COPD is excluded. In a COPD patient, spirometry is most of the time abnormal. ABGs are only performed if the oxygen saturation is less than 92%, if the patient has altered mental conscious, if the patient has acute exacerbation. If the patient gets an acute exacerbation, in that case, you need to get ABGs. Chest X-ray will show hyperinflated lungs, barrel chest. Since the patient is unable to exhale the air out, the patient's lungs will be hyperinflated. Look at the hyperinflated lungs. Look at the flattening of the diaphragm. Look at the tubular heart. Since the diaphragm has gone down, the heart is hanging in the chest and it becomes like this, a tubular heart. This is a picture showing increase in anteroposterior diameter of the chest, showing barrel-shaped chest. This increase in anteroposterior diameter occurs due to obstruction of air within it. This is a CT scan showing the bullae of lung. Or most of the time it happens that these alveoli gets destroyed, then they form large bullae. These are called as emphysematous blebs, and they sometimes rupture, resulting in pneumothorax. So this was ABGs and chest X-ray. Now another important test is alpha-1 antitrypsin deficiency test. It is recommended for all patients with COPD, and especially in patients who are young. Alpha-1 antitrypsin deficiency must be tested. CBC shows increased hematocrit in COPD patients. Why CBC shows increasing hematocrit? Since these patients are unable to exhale the air out, their oxygenation levels is chronically at a lower level. They have low oxygen, they have chronic hypoxia in their blood. Chronic hypoxia stimulates the adrenal glands to secrete more and more erythropoietin. So more erythropoietin is secreted, and these patients will have high hematocrit. Another thing that you would see in your books is Centriacinar and Panacinar emphysema. This is a picture showing normal alveoli with a normal respiratory bronchiole. In Centriacinar, what happens is that the alveoli are fine, but the respiratory bronchiole is destroyed. In Panacinar, the whole respiratory bronchiole as well as the alveoli, all of it are destroyed. Panacinar usually involves the lower lobes and is more common in alpha-1 antitrypsin deficiency in young patients who suffer from COPD. Centriacinar mainly occurs due to smoking. An important thing to remember is that if the patient has no smoking history, patient is young, and that patient presents to you with COPD, you should consider alpha 1 antitrypsin deficiency as a cause of COPD. Now, coming to the treatment of COPD. In the treatment of COPD, there are many aspects that you have to cover, but bronchodilator therapy is one of the most important ones. In the bronchodilator therapy, if the patient is having mild COPD, in that case, you can give short-acting beta agonists like albuterol. Albuterol 90 microgram per puff inhaler can be given, and patient is asked to inhale it 4 to 6 hourly. Long-acting beta agonists like salmeterol 50 microgram inhaler can be used, and patient is asked to inhale it 12 hourly. Long-acting beta agonist inhalers are preferred because these patients have a baseline disease, and long-acting inhalers have longer duration of action. Long-acting beta agonist inhalers like salmeterol, they have longer duration of action, and patient can continue this. In COPD class B, long-acting muscarinic antagonist or long-acting beta agonist salmeterol can be given. In COPD class C, long-acting muscarinic antagonists like tiotropium bromide 18 microgram once daily can be used. They have a long duration of action. And other than that, patient can be continue on these LAMA or LABA inhalers. Otherwise, patient can also use LAMA and inhaled corticosteroid combination. In COPD class C, you can go for either a long-acting muscarinic antagonist like tiotropium bromide alone or in combination with LABA or inhaled corticosteroids. And if the patient is having severe COPD, you can use a combination of long-acting muscarinic agonists like tiotropium with long-acting beta agonists like salmeterol with inhaled corticosteroids, and you can add macrolide like azithromycin to prevent infection. Now remember, long-term oxygen therapy LTOT is a very important part of the treatment of COPD patients. These COPD patients are not maintaining saturation, and if their saturation is less than 88%, they must be given long-term oxygen at home, cylinders at home, and the target of oxygen saturation should be 90 to 93%. Remember, never give 100% oxygen to a COPD patient. If you give 100% oxygen to a COPD patient, it will cause depression of the respiratory drive, and they will develop excessive CO2 retention. Now, how does this happen? Why do you not give 100% oxygen in COPD patients? I have talked about it in detail in my video on COPD exacerbation treatment. And remember, oxygen therapy improves mortality in COPD patients. Mucolytics like N-acetylcysteine can be given in nebulized form, orally or IV. They break down the mucus and remove the mucus and relieve the obstruction. Theophylline can be used in severe or refractory COPD, but theophylline have increased risk of arrhythmias. Surgery can be performed if the patient has severe form of COPD which cannot be treated with these medications. If the patient develops complications like rupture of blebs, in that case lung transplantation and removal of those blebs can be done by surgery. Smoking cessation is the single most important intervention. If a question comes that asks you that the single most important intervention in the treatment of COPD is, that is smoking cessation. Vaccination is also performed since these patients are having chronic condition, chronic comorbid condition. These patients are at increased risk of infections. Influenza dose is given yearly. Influenza vaccine is given yearly. With that pneumococcal vaccine, if the patient's age is greater than 65 and if the patient has COPD, that patient must be given a pneumococcal vaccine, polysaccharide vaccine. Chest physiotherapy with postural drainage of the mucus is also advised. Remember, the two things that improves mortality in COPD patient is smoking cessation and long-term oxygen therapy. Complications of COPD include chronic respiratory failure. Since these patients are chronically hypoxemic, chronically low oxygen, they can go into chronic respiratory failure, and that can be treated with long-term oxygen therapy or home oxygen therapy. Lung volume reduction surgery can be done, lung transplantation can be done. Since their lungs are destroyed, their lungs are damaged, and the right side of the heart pumps the blood to the lungs. And if the lungs are damaged, the right heart has to put more effort in getting the blood oxygenated. So the right heart of the body is overstressed, the right side of the heart is overworking. So it results in the right heart's failure, cor pulmonale. And spontaneous pneumothorax by rupture of the emphysematous bleb can also occur. In summary, we talked about the causes of COPD, we talked about the GOLD classification, the symptoms according to the Dyspnea scale and the CAT score, the clinical features, the diagnosis with spirometry and the chest X-ray findings, alpha-1 antitrypsin deficiency, the treatment according to this classification, long-term oxygen therapy, theophylline, mucolytics, smoking cessation, vaccination, and measures that improve mortality complications of COPD. If you liked my video, please click on the subscribe button and check out my other videos on pulmonary medicine and emergency medicine. I have also made a video on detailed management of asthma. You can check out the link of those videos in the description below. Thank you very much.